Hi, everybody. Welcome back to Health Law Simplified, where we break down complex healthcare regulations into actionable insights for you. So, today we're going to be diving into a major development from CMS that's sending, I don't think it's an overstatement to say, shockwaves through the Medicare Advantage industry. So just last month, or I guess in May, 2 months ago, CMS announced a sweeping expansion of its risk adjustment data validation audit program, known as the RADV audit program, which is a significant escalation in the agency's efforts to combat fraud, waste, and abuse in Medicare Advantage. Elizabeth, I know you've looked at the memos and output from CMS. Can you just tell us what's changing in RADV?
Yeah, definitely. I'll say first of all, I try not to be alarmist, but I'm really worried about the scope and pace of these audits for plans, especially smaller plans. So historically, CMS has been doing risk adjustment data validation or RADV audits for many years. Generally, they've only audited a small sample of plans, about 60 per year. Starting right away, they're going to audit all eligible MA contracts every year. So roughly 550 plans per year. So a nearly tenfold increase. They're also working to clear a major backlog of audits for payment years 2018 through 2024. So they want to complete all of this by early 2026. I will be surprised if they can pull it off just due to the magnitude of what they're setting out to do, but that's their stated goal.
Thanks, Elizabeth. I know that we do have some listeners who are really steeped in Medicare Advantage and others who are newer to this space. Can you just really briefly explain why CMS conducts this type of oversight on risk adjustment, and if you have any thoughts as to why it might be cracking down now?
Yeah, oh, definitely. So, Medicare Advantage payments, so the payments going from CMS to the Medicare Advantage plan are based on specific information about each enrollee. So, the bid amount is adjusted up or down based on, easy to determine demographic factors like sex, original reason for being on Medicare. So, if they had Medicare due to disability or if they aged in, and age, of course. And then they're also adjusted up or down based on the health status of that individual. So the sicker the patient is, the higher the payment because the government anticipates that they're going to have higher health care costs. So CMS takes all of that information in from plans, but it also audits the quality of that data because they don't want to be overpaying. If, for example, a Medicare Advantage plan sends information that an individual has diabetes with complications, that has higher reimbursement associated with it than they just have diabetes without complications. And estimates suggest that MA plans may be, quote, overbilling the government by $17 to $43 billion annually in connection with these risk adjustment data submissions. So that's why CMS is now taking really aggressive steps to recover those funds.
Thanks, Elizabeth. It just occurs to me that it's worth pointing out that there are really good policy and practical reasons to adjust payments based on the sickness of or health of enrollees. It's more expensive to take care of patients who are more sick. And this payment setup that CMS put in place, well, it prevents plans from doing something that was called lemon dropping, where they specifically did not enroll patients who were more sick and would be harder to take care of. So, we want plans to be enrolling everybody, even if they're sick.
Right. And we want them paid appropriately for what we anticipate, what the government anticipates the costs will be for those individuals.
So do you see this as consistent with the actions that we've seen across other parts of the executive branch to combat fraud, waste, and abuse?
I do, and that's what they've stated. They're going after what they see as fraud, waste, and abuse very aggressively. What concerns me here is that the way these audits are conducted, there are situations where there really isn't fraud, waste, or abuse. There's just not ideal documentation, especially for plans that are running at a loss. There are a lot of contracts out there that are operating at a loss or at a very thin profit margin. This may be the difference between them wanting to stay in the business or not.
Yeah, that's a really good point. When we hear words like overbilling, it gets lumped in with fraud, but RADV is very different from a whistleblower lawsuit. These payments. So if a plan receives a payment for a condition that's not documented, that's not usually fraudulent. There doesn't have to be any kind of bad intent. It just means the documentation standard wasn't met. And I think that's a really important distinction. So just because a plan gets a bill for an overpayment coming out of a RADV audit, it doesn't mean there was any fraud at all.
Right. And plans are depending on providers to have the right, words in their notes to substantiate under the coding guidelines these diagnoses. So in some cases, I think it's important to understand that certainly a bad outcome in a RADV audit doesn't mean there's been fraud necessarily, and it doesn't even necessarily mean there's been waste or abuse. It just means that the plan could not produce the complete supporting documentation the CMS expected. That's a little bit of editorializing, but I think it's important for people to understand.
I agree, especially since all of this is being put under the umbrella of fraud, waste, and abuse. It's a little more technical than that, as is often the case.
Yeah.
So I want to drill down on the change in scope. You noted that historically CMS audited a much smaller number of MA plans, around 60 per year. I want to go back even further. For many years, CMS was only auditing 30 contracts per year, and it was looking at, for each contract, a random sample of 200 enrollees. And then it changed its methodology more recently, pre-pandemic. It started targeting specific diagnosis codes that were at higher risk of being unsupported. And at that time, CMS said, we're going to look at smaller samples, around 35 members per contract, and that this will allow us to look at many more contracts. And so at the time, CMS said, we're going to look at 188 contracts per year. And now we know with hindsight, that was incredibly ambitious. That, to my knowledge, never happened. I don't think CMS ever got close to that number. And by its own reporting, only ever averaged around 60 per year, which raises the question, I think, that all of us who are in this have, which is, how could CMS possibly accomplish its stated goal of auditing all 550 contracts annually?
Yeah, valid question. Well, according to their press release announcing these audits, they're going to do it using technology, for one thing. So they have new advanced systems to flag unsupported diagnoses. I think the assumption is that they're using AI tools to analyze the data and hone in, as we saw the Office of Inspector General, the OIG, doing in their targeted audits on where they anticipate there'll be problem areas. They also say they're planning on beefing up their workforce. So they intend to increase their staff of medical coders from 40 to 2,000 by September 2025, which would be a feat of hiring, but we'll have to see. And then in terms of the scope of the individual audits, instead of reviewing 35 records per plan, they're going to review up to 200 records depending on the size of that particular plan.
It's very ambitious. It makes you wonder how many of the folks who were laid off from CMS would have that medical coding certification such that they could come back.
Yeah, coding would be a good thing to study right now. I don't mean to make light of people's transitions. But yeah, good
No,
point.
I looked at it myself today. It seems like a useful skill to have. So I think what people are really wondering about are, what are both the financial implications and the legal implications of these RADV audits. One thing that is very relevant to this discussion is extrapolation. So in 2023, just a couple of years ago, CMS passed a final rule allowing it to extrapolate its audit findings. So what that means is if the little sample that CMS looked at of 35 contracts or 35 members or 200 members has an error rate, CMS can multiply that error rate out across, for all intents and purposes, the entire plan population, which has the potential to lead to really massive financial recoveries. So for MA organizations that are facing these audits where CMS will be using the extrapolation methodology, they have much greater financial risk. Do you have any thoughts, Elizabeth, on what the size of the bills that these plans could be facing could be?
Yeah, they could be quite large. I mean, we took a look back at the OIG has been publishing its findings and the extrapolation amounts. And for fairly small plans, just estimating like 10,000, 20,000 members, it's not unusual to see extrapolation results using the OIG's method, which was they weren't necessarily random sample audits, they were targeted. So they used a different extrapolation methodology, but it wouldn't be unusual to see maybe a $3 million a year finding for a small plan that's not really an outlier in terms of its results. And so you multiply that by 5 years, 6 years, those get to be really, really tremendous bills. And then it just goes up from there depending on the membership.
Yeah, and all of that is regardless of whether or not the plan is profitable, which
Right,
for a
right.
small MA plan, it may very well not be.
Especially for a new plan, when plans start out, it's common for them to say, okay, it's going to take us 5 years to break even. So, yeah, it's not unusual for plans to run at a loss or have pretty modest margins that could be wiped out through one of these audits. So it begs the question: if you're committing fraud, like, why are you losing money? So anyway, I'm a little cynical, but that's just where we are. So what else do we know about how extrapolation will work, Sandy?
Yeah, so in the extrapolation rule that CMS finalized, it did not adopt any specific sampling or extrapolation methodology. It said we are going to rely on any statistically valid method for sampling and extrapolation that is determined to be well suited to a particular audit. So CMS really has carte blanche to tailor its approach, to change its approach, to try new approaches, which is what we've seen CMS doing in the audits that it's been conducting over the last several years. And it's worth noting that statistical validity, that's all that's required for the extrapolation methodology to hold up in court. So that's what CMS has said it's going to do, and that's what we can expect. CMS has also said we're not even required to tell you how we're going to extrapolate. There's no law that says we have to disclose our methodology. Nevertheless, we will give an audited organization enough information so that they can at least understand how we are extrapolating payment errors. And CMS also said, there may be circumstances where it doesn't make sense and we will choose not to extrapolate. But what we know for these RADV audits going forward is that CMS does plan to extrapolate in, the vast majority of circumstances.
Yeah. And it's interesting. We have some insight from the documents that the OIG has published, its reports on its targeted audits, the way it uses the sampling frame in a targeted audit. So, for example, if they're looking at diabetes codes and they find an error rate based on their review of samples of that particular type of code, then they will extrapolate to members who were enrolled for the whole time period being reviewed who had reports of the same diagnosis code. Did I get that right?
You did. And actually, I'm glad you mentioned that because that research really did give me some comfort. I had
Yeah.
some fear when I first read CMS's announcement that it was planning to target high risk diagnoses and then extrapolate because it really does not make sense to multiply an error rate that's based on error prone enrollees or diagnoses and then multiply it across an entire contract. But it looks like the plan is, or at least based on what CMS is doing currently, that it's structuring sampling frames that are made up of those high risk codes or enrollees and only multiplying across that sampling frame, which is a smaller subset. That said, it's still going to be really significant in terms of financial exposure for plans.
Yeah. And, you pulled this example, but in the most recent OIG audit, the enrollee level overpayment that they identified was about $750,000. And then after extrapolation using the sampling frame, the contract level overpayment was $6.9 million. So even though it's, limited to the sampling frame, it can still, the numbers can add up pretty quickly. And my understanding is that was a pretty small plan.
And another point when we talk about financial risk that I don't want to be lost is not only is CMS going to be extrapolating, but historically, CMS, although it's been conducting RADV audits annually, it hasn't actually been collecting all of the overpayments at the contract
Right.
level. So
Yeah.
the last big recovery was for the audit of payment year 2007. And that's what CMS means when it says we're going to clear out our backlog. It means we're going to go back and collect all those recoveries that we calculated for the years past.
Yeah, and then they have authorization under the rules to extrapolate back to 2018.
Yes. Yes, that's a
Yeah.
good point. They won't be
Yeah.
extrapolating back to 2011 through 2017.
Well, and we have that announcement that they're getting more serious about collecting these amounts and doing that going forward, but we know there's litigation pending that could hold that up, and that there are appeal rights, although the grounds for appeal are quite limited. So there is a chance that this could move forward. The bills could be sent out, figuratively, but then there could be continued delays with these liabilities kind of out there.
Yes, absolutely. I think the litigation you mentioned is the Humana lawsuit challenging
Mm-hmm.
the extrapolation rule. And I will say, we've been monitoring for challenges to this current RADV audit expansion, this announcement. I don't think it is immune from legal challenge. I think there are arguments to be made that CMS exceeded its authority by so significantly changing its methodology without any notice in a way that's really has the potential to upend the industry. So I expect there will be a legal challenge, and we'll stay tuned for that one.
Yeah. Yeah.
What are your thoughts, Elizabeth, on the administrative burden? Just setting aside the potential for recoveries, how hard is this going to be for plans to implement?
Very, very hard. I mean, just an old-fashioned RADV audit was extremely difficult to support. And, if you think about it from the plan perspective, the onus is on you to pull all of these medical records and find the documentation that supports the codes you submitted. That's not always easy to do. If you in an ideal situation, you have access to a health system's electronic medical record to do that. But there are going to be a lot of situations where you're having to pull paper charts. And if you think about it, if this is all happening at once, every Medicare Advantage plan is going to be going to the same providers asking for medical records at the same time. So, at the provider end, there are going to be resource limitations on producing all of that documentation. So it's going to be quite challenging at a difficult time. It's a difficult business environment right now for a lot of other reasons, as we've been discussing on the podcast for Medicare Advantage plans. So I think it's going to be pretty tough.
It makes my head spin every time
Yeah,
I think
no.
about it.
Yeah.
And then there's also the expedited time frame to submit deletes. Plans used to have 4 to 6 years to submit deletes for a payment
Oh,
year.
yeah. Yeah. Yeah.
And now they've got 6 months.
Yeah. And the significance of that, what we're talking about when we say submit deletes. So you need to be doing quality control, both for looking back at medical records and finding both, the ideal two-way chart review. You're looking for diagnoses that you missed that were not coded already. And then you also need to be looking for diagnoses that were coded that you don't have the right documentation for. What we're talking about when we say submit deletes is the plans have now much shorter windows to submit deletes of diagnoses where they've looked back at the records and they're like, yeah, we don't have all the elements that we need in the doctor's notes to support this diagnosis. Whether or not the person actually has it is a different question. It's all about the documentation. So that could lead to higher error rates just because the time for that quality control has gotten shorter, a lot shorter.
How those higher error rates will translate to larger
Higher
recoupments. Yep.
extrapolations. Yeah. Yeah.
Well, with all of that, what should folks who are listening who are impacted by this be doing? We know that some plans have already received audit notices, but for
Yep.
those who haven't,
For 2019, the
Mhm.
2019 ones are circulating now.
Do you have any recommendations for compliance officers or counsel working with a health plan?
Yeah, have an audit game plan. I mean, have thought through what your action plan is going to be. Understand what your timeframes are likely to be for gathering the documentation. Do what you can in the very limited time allowed to do some quality control to the extent that you're able to review diagnoses where you have the documentation available or can get it really quickly. Be prepared and make sure that your senior leaders are aware of this audit program and what it could mean, and that they're prepared for these extrapolated liabilities. And I would also say, if you are going to need support from consultants or outside counsel, get that lined up, I would say, even before the audit notices come, because there's going to be a bit of a scramble once everybody is going through this in fairly short order.
That's great advice. Not legal advice, great practical suggestions. And then I think, a sort of evergreen recommendation is, if you haven't dusted off your coding guidelines, your documentation practices in a while, now would be a really good time, because those industry standards have been evolving rapidly, and a lot more of your records are about to be scrutinized by CMS.
Yeah. And I have to say, okay, I'm going to get really Debbie Downer now. Sorry, this is not the most upbeat episode.
We forgot our positive focus. Maybe we can end with that.
Oh, no, I forgot my positive focus. Okay, but what this reminds me of policy-wise is sort of the Medicaid cuts that are going to likely impact a lot of rural hospitals and lead to more closures, or recently temporarily closed hospitals. I live in North Carolina, so it's a big factor here, are likely to remain closed, have no chance of reopening. And so it's really going to affect access to care and, people's lives. And I don't know if the kind of, cause and effect analysis is being done carefully on some of these things. And to me, this is another example of that. Like, if you design this audit program, it's super aggressive. It's couched in terms of fraud, waste, and abuse, where I see it more as a, quality of documentation type exercise in many ways. these audits are going to be done, these bills are going to be sent out, and then what's that going to mean for people's choices for Medicare Advantage plans? Are we going to see more consolidation? Are we going to see a lot of small players dropping out of the market, or, shrinking their service areas? Are we going to see some of the larger players reevaluating? We're already seeing some of that, exits from the market. So I'm really worried about what the end stage of this process is going to look like. I hope it's less severe than I fear that it is, but I just wonder, what the MA marketplace is going to look like in 2-3 years after this all shakes out.
That is
That's
a
my
good
Debbie Downer
analogy.
commentary. Yeah.
I think, without getting political, I think the unintended consequences and the administrative burden of all of these really intense government activities and requirements are going to have an effect on access to care. And I'm also with you on, we'll see what happens in a couple of years.
Yeah. We'll be here.
Do you have a positive focus for the week?
No, I didn't.
That's fine.
Yeah, I needed to. How about you, Sandy? Do you have positive focus?
On risk adjust? Yeah, I do actually.
Okay, good. I'm so glad.
One of the things that has made risk adjustment such a fraught area for plans has been all of the gray area. CMS has not issued updated guidance for many years on actual coding practices. They have their RADV medical record reviewer guidance, but even that is at least 5 years out of date. So, silver lining, plans are going to be getting a lot of direct feedback from CMS on what kind of documentation is sufficient to support a diagnosis and a payment. And that kind of information will be very, very helpful to our clients that just want to do it right? That want to follow the rules and are risk averse. So I am hopeful that this increase in engagement from CMS will translate to some more predictability going forward. And maybe that's pie in the sky, but that's what I hope.
No, that's valid. And then maybe if they're seeing common themes, they will put out some updated coding guidance to clarify. Yeah, that would be a positive outcome. So thank you.
And maybe none of this will get collected.
Maybe we'll see.
All right. Well, thanks for being here and talking us through this announcement.
Yeah, thank you. Same.
At the very least, it's nothing's boring in Medicare Advantage.
That is true. Good point.
All right. Thank you. Bye.
Thanks, Sandy. Bye-bye.
If you enjoyed this episode, please subscribe wherever you get your podcasts. And if you want to find out more, go to strategichealthlaw.com. This podcast is for informational purposes only and should not be considered legal advice. If you need legal advice on any topic we've covered, please consult an attorney with appropriate experience in health law. Our music is Galaxy Love by Johnny Duke. Until next time, thank you for listening to Health Law Simplified.